So good afternoon to one and all present here today for the session on advances in neuro rehabilitation in association with Kaveri Hospital and Hamsa Rehab Center in Chennai. Today we have eminent speaker Dr. G. Balamurali sir, one of the renowned spine and neurosurgeon in Chennai. Welcome you, sir, for this session, and thank you for accepting this invite and agree to address the audience on various advancements and rehabilitation practices practicing by you, and also a couple of case studies. If possible, if you can share, that would be really great. And for the audience, I don't have to give much introduction because Dr. Badamurli sir has been practicing, spine and neurosurgical process maybe more than 25 plus years, doctor, if I'm right.
Yes.
So this experience will value at the session. Over to you, doctor.
Thank you. Thank you so much. Good afternoon, everybody. I'm Dr. Balamurali, spine and neurosurgeon at Kaveri Hospital, Chennai, and managing director of Hamsa Rehab, which is 3 years old. And because of my passion for rehabilitation is what I started this center. I'm not a PMR specialist, but with my knowledge about rehabilitation for the last decade, I'm going to present to you some of the advances, specifically in neuro rehab, which is my area of interest. So when it comes to rehabilitation, there is a lack of knowledge, I would say a lack of understanding in general among the medical community, unless you are specifically related to that. Either you're a PMR specialist or an physiotherapist, occupational therapist, speech and language pathologist. General doctors are not very familiar with what exactly happens in terms of rehabilitation. So that's one of the things that has to change in our country. People need to be more aware of the importance of rehabilitation as much as an acute care. And also, there is a lot more advances that have come in the last 10 years in terms of rehabilitation. So I'm going to touch upon some of those advances in neuro rehab in this juncture, and I'm going to explain to you what are the things. Some of them are probably available in India, some of them are not available in India, but just for you to understand a snapshot of what the advances in neuro rehab that is available. Now, I trained in the UK. I was there for nearly 16 years, and there are 11 centers for a population of about 53 million. There is an approximate of 1,800 beds in the acute and 3,000 beds for the elderly. The reason I put this data is if you look at India, I would say there are 2 major centers in Delhi and few other places, and there are, which have about 100 beds. And the rest of the hospitals, mostly there are about 50 beds, 20 beds. And there are lots of smaller outpatient, inpatient based rehab, and every hospital has a little rehab, but it's not really a specialist run, a team run rehabilitation center. So for a 1.3 billion Indian population, we have less than 1,000 dedicated beds for rehab. I have traveled extensively in India. I have seen many rehab centers. Some of us are doing extremely well with the limited resources, but not many are advanced. But there are a few advanced centers in Mumbai, Hyderabad, Bangalore, Chennai, Delhi, but not so advanced in most other centers. So also the number of rehab doctors that come out every year compared to acute doctors is very, very less. It's hardly difficult to find. It's very difficult to find a rehab specialist. Even in Chennai, we only have a handful of doctors who are rehab specialists. Today I'm going to talk to you about a few important things. One is when to start rehab. So the question is about, at what point do you start rehab? And here's a snapshot of, compared to the rehab doctors, the number of specialists who are there. Acute rehab is something that is very important for us to understand, that we need to start rehab from the acute phase. For example, if a patient has a stroke, the rehab should start from within a few days after the acute care, whether it's thrombolysis or thrombectomy. or whatever treatment is given or surgery, the rehab should start from that point of time. Acute care is well established in our country. There are plenty of doctors. For example, if you just take Chennai, you probably have anything from about 100 to 150 neuro and spine surgeons to treat brain and spine injuries. But if you take rehab doctors, there's probably less than about 5 to 7 of them. So acute care is well established. It's scientific. There's enough evidence. The reimbursement is good. Whereas chronic care or rehabilitation is all about quality of life. And not many of our Indian public itself have this mindset of providing that rehabilitation service for good quality care. There's not much evidence. The reimbursement is not very good. So neuro rehabilitation is one of the areas where I would say 70 to 80% of rehabilitation is focused more on neuro rehab worldwide. And then comes orthopedic, cardiac, pediatric, and other things. So after an initial injury, there is significant neural damage. And disability is very common in both stroke, head injury, and spinal cord injury. You either get complete or incomplete deficit, and there's a lifelong disability which is present. Rehabilitation is all about learning new skills, giving them a quality life, and avoiding complications. So how are they going to live with this complication? The common question asked by patients is, oh, will I walk? Will I become normal? And it's very difficult for a doctor to say that, no, you will not walk, but we will improve your quality of life. But for the patient, it is all about, well, if I'm not going to walk, what quality of life am I going to have? So that is where we need to communicate. And that's one of the important things for all rehab specialists is about how you communicate to your patient and make the negative message positive, at the same time, not giving them false promises, but trying to tell them the positive side of the worst case scenario. So in terms of what is very unique compared to rehabilitating somebody with a TKR or a post-angioplasty or a pediatric, a child with autism or cerebral palsy, what is very unique in specifically in terms of neuro rehab is, the patient groups are not that easy and they are the most difficult to rehabilitate. For example, you have patients with low conscious level, there's loss of memory, the cooperation of patient, they may be aggressive. A lot of patients are on tracheostomy. They need intermittent oxygen, regular suctioning. They have speech and language problems. They have swallowing problems. They may be on, enteric feeds. They are having contractures, bed sores. And these patients are very not cooperative. They are financially exhausted, emotionally exhausted. None of them want to live. So these are the most complex group of patients who require rehabilitation, in my opinion. Probably the spinal cord injury, the paraplegics are the easier ones to rehabilitate, whereas the brain injury and stroke patients with severe disability are the most difficult ones to rehabilitate. And rehabilitation is all about a teamwork. It's about a team of rehab physicians, nurses, therapists, OT, PTs, psychologists, speech and language, dietitian, and so many others. It forms a full team of people who can do that. And also a group of doctors you require, from a rehab physician to neurologist, to neurosurgeon, to spine surgeon, neurologist, psychiatrist, and physicians. So it is a very big teamwork. Getting the team aligned with the common goal and the patient in the center is very difficult. So neuro rehab generally is for stroke, brain injury, for spinal cord injury, neurodegeneration, for Parkinson's, Alzheimer's, various forms of sensory and motor ataxias, post-operative patients, cerebral palsy in the pediatric age group. The challenges we see in India is, the beliefs and acceptance of patient that they may never walk, they may have permanent neurological deficit, that their speech and language areas affected, they may not talk, understanding their needs, cost. Insurance is not widely available. Recently, Star Health has come up with some products. There's lack of, healthcare providers and specialists for these people, and the patient understanding as well, and the caregivers understanding also is not there. There's so many alternative treatments in India people opt for, and recognition among healthcare specialists. So the focus should really be on awareness of the problem, learn to live with the disability, avoiding any complications. It's a lifelong guidance and teamwork which are required. So let's first talk about a few debates in rehabilitation, which is there about early versus late. So a lot of people think that, okay, once the patient has a stroke, we'll send them home to recover for about 1 week, 1 month, and then come back after 1 month, and then we'll think about rehab. And patients also, they're exhausted financially, emotionally, so they want to leave the hospital. So they leave hospital, go away, and then they think about whether they want to come for rehab. So the answer to this question is there is enough evidence to say that better outcomes are present when early rehabilitation is started. So early rehabilitation, meaning from acute care, they go to subacute care, they come to rehab, and they start with continuous rehabilitation for about 3 to 6 months after that. So rehab definitely should be started in the early phase. There is very few contraindications to why we should not start rehab in the acute phase. So it is associated with an increased time from injury to rehab, and poor quality of life and the performance of ADL. So all of these things are directly proportional. So the earlier rehab, better quality of life, better ADLs. So there is really not much of a debate there as to how early rehabilitation should be given. Next thing is about how early mobilization should be done. Whether you want to do early mobilization versus late mobilization. We all know that patients who are in bed for longer than required are going to develop various complications, including atelectasis of the lungs, chest complications, pneumonia. They are going to develop problems in the bed sores, depressed, and there are so many other problems that they may have. And there is enough evidence to say that early mobilization, getting them on the balance boards and the tilting table, the sooner the better. Getting the trunk control early is beneficial, and there's significant reduction in acute care and total length of stay. High significant reduction, and increase in decrease in all the complications starting from day one. So there are plenty of benefits. Also, the benefits are you prevent DVT, MI, pneumonia, and so many other complications by mobilizing them early, both in stroke patients as well as spinal cord injury. And how early is, I would say, as early as 2 to 3 weeks when the patient's medically fit. Now, let's talk about advances in the rehabilitation. So when we talk about advances, let's talk about in early phase of rehab, what are the advances that are there? Skin care is one of the commonest problems. So, how do we prevent these skin scares? The best gold standard is regular turning. So you need to have a chart which documents that, and you have turning every 2 hours. The patient has to be turned. Either the patient, they can turn by themselves if they are conscious enough and well, or the carer should give reminder. All the nursing team should do proper turning. There are lots of beds and materials which are available which reduce the pressure up and down. It inflates the pressure on one side, gives them relief. The airbed concept is a very good concept, and it is a low cost and effective way of doing this. But if you have opportunity to get something better, then yes, there are plenty of devices which try to alter the pressure, especially in the acute phase and when the patient is not yet sitting or standing. So in terms of respiration, again, there is a lot of things to treat respiratory complications, because patients with tracheostomy can develop so many other problems. So there are silver coated endotracheal tubes. Use of early tracheostomy associated with lower rates of pneumonia, shorter periods of mechanical ventilation. So sometimes in high quadriplegics where you have an acute injury, sometimes I do an anterior neck surgery and at the same time I do a tracheostomy, because I know that the patient has a very high chance of going into respiratory failure and requiring long-term ventilation. So tracheostomy will allow them to bring them out of ICU very quickly. So the tracheostomy and chest-related complications can be reduced. Pain management. So pain management is one of the commonest problems. If you look at the different types of pain, whether it's visceral pain, whether it is neurogenic pain, 80% of people with spine, brain, and stroke problems will have some sort of pain. 70 to 80%, and 60% of them have lifelong pain. So there are so many other devices and medication and techniques to do apart from just painkillers. Some of them are on opioids for a very long time, and various neuromodulation medications which don't work. So we can do various procedures like, spinal stimulation or an intraspinal pumps, which are pain relief. Not necessarily palliative care, but also it is very good in pain management. So we can use, electrical stimulation like a DBS, deep brain stimulator, spinal cord stimulator can be used. Sometimes we also do operations like DRES lesioning, so dorsal root entry zone rhizotomy. So I do a lot of these in the brachial plexus and sciatic and the lumbar plexus for spinal cord injured patients, and it caused excellent results. I've operated at least 30 patients who have had a severe spinal cord injury related neuropathic pain in the legs. And these patients do not respond to any conventional medical or other therapeutic measures, and DRES lesioning really helps. So it's a very long, tedious operation, but it does have benefits. The alternative to that is an expensive form of spinal stimulation, where you can place in a spinal cord stimulator. It again needs a team effort of a neurologist, somebody who can interpret neuro signals and try to identify the source of pain, the level of pain, and from there you place in spinal cord stimulator, and you can use continuous stimulation, and that also helps. Intrathecal spinal pumps, they are mostly used for spasticity, because spasticity can lead to pain, and people who have severe spasticity can develop pain in future. So we do have surgeries like a baclofen pump, which is a very small little tube that can be inserted in the spinal cord, with a little pouch, and which holds the baclofen, and it is released continuously in small quantities throughout the day. And this keeps the spasticity low. And so by reducing spasticity, you reduce pain, you reduce all the complications related to spasticity. So this is how one of these pumps are. It's a young boy who had a spinal cord injury that we had operated. So then the other things in terms of bowel and bladder care. So bowel care, there's a lot of irrigation systems which have come. And I've not used any of them. I have no experience, but I have seen them, presentations. I have seen bladder stimulator, the Brindley bladder stimulator, and there's a lot more available commercially now in the market. So these are used to stimulate the sacral anterior roots. And it can be combined with various rhizotomy and dorsal procedures, but it definitely improves the quality of life, continence, and reduces the number of urinary tract infection. It is an expensive procedure. Not too many comorbidities, but yes, but it is quite expensive to do these procedures. But they are of benefit for the patient, especially depending on the type of patient who is very active, who's at work, and who needs bladder control, and they are physically fit to be mobile. And these are the patients where we should think about bladder stimulators. Now let's talk a little bit about the technology. Technology is there everywhere. And healthcare is one of those areas where technology is far advanced in the last 10 years. I've seen in my own career in the last 20 years, from using some very, very basic technology to very high advanced robotics in terms of rehabilitation. I'm not aware of the major benefits of technology in terms of outcome, but definitely there are lots of evidence saying that with certain technologies, for the appropriate patient, there is benefits. So we cannot discard saying that, oh, technology is too expensive, it is not for India, we cannot use it. I don't think there's going to be any more the argument. So definitely technology has some benefits. So what are these technological changes that we can see? So the technology changes we can see are in terms of virtual reality. So this is one huge area that's emerging in terms of how you can do cognitive therapy, you can do coordination, you can do hand function, you can do memory training. So there are so many computer interface technologies which are available both locally and imported. And definitely these are fun, especially in the pediatric setup. It helps with, again, for adults, they get bored after some time, and the compliance increases in terms of patients with virtual reality. They want to have these games and fun. So there are various other things that we can use in functional training. For example, the functional electrical stimulation. So these are also present wireless and Bluetooth operated, and so these cause continuous stimulation externally and can be used for muscle strengthening and for biofeedback. So this is something that's being extensively used. And it's there both available for upper limb, for trunk control, as well as for the lower limb. So this is being widely again used. So these are some very advanced things which I have never seen, but I'm sure that this is something that's going to be coming up in the future. Our free hand systems. So an implanted FES device is intended for restoration of hand function. So again, it's very similar to a pacemaker for the heart, that you can fit these devices in the hand to stimulate certain functions. And there is more advanced ways in which there's a brain controlled interface as well, which we'll talk about. So these systems again have a great advantage in improving function both at the bedside and outside. So robot aided neuro rehabilitation is becoming very common in India. So this again improves the interface between the patient and the therapies. So I'm not sure if the robot itself is useful in improving the strength, but the patient's compliance, the patient's cooperation, the patient's acceptance is becoming higher. And in another 10 to 25 years, I'm sure this is going to be revolutionizing the way we do rehabilitation with robot aided various things, both for hand, for gait, as well as for lower limbs and for balance. So there are so many balance trainers and there are so many balance machines that can be used. And especially for hand function, robot assisted rehabilitation in the hand. So the brain machine interface is going to be a future research tool. I'm not sure if it will be available in the next decade or so, but when somebody has a spinal cord injury, say for example, and a higher cervical injury, so we have already got certain stimulators like phrenic nerve stimulator for the diaphragms. Same way for limbs, we have the brain machine interface, where actually the electrodes are directly connected from the brain into a computer or a software which controls your function. So the brain component is that you're bypassing the pathway completely of the spinal cord, and the brain is directly using the hand either through prosthesis, artificial limb, or directly the patient's hand through functional stimulation. So this is something again you can see that the patient's blinded, but whatever he thinks, these are converted from electrical impulses into digital impulses and the hand function. So if you think about that, you want to lift a cup and your brain thinks about it, and this robotic arm will do. And you can see that there is an electrode. There are various electrodes in this person's brain which are useful. Exoskeletals, again, in Chennai, there is a company that manufactures this. So it is again becoming common. It provides, good gait assistance to spinal cord injury population. And again, this is something which was originally devised for the US military, because you had a lot of soldiers, especially in the Afghan war, who lost their limbs. And this was something that was used for them. It's becoming more widely used, very expensive, the very good ones. But definitely this is something that helps with patients who have lower thoracic injuries where they have trunk control. If you don't have trunk control also, I'm not sure if there are exoskeletals for that as well. So robotic, aided gait training, balance training is very common. Now coming to adaptability. So, we've seen how to do the strengthening and training, and now it comes to how are you going to adapt to the environment in terms of mobilization, in terms of your activities of daily living. your bed, your home environment, your transportation. So how are you going to adapt to various situations with the disability? We have all these different, wheelchairs, which are, the standing wheelchair, the mouth control wheelchair. You have so many of these advances which have come in terms of how do you control speech or touch, or various other functions in terms of functionality. So I think, it's just about the imagination and engineering. That is all that is required for a lot of these adaptability devices. Driving again has become very easy with hand control systems, and at the same time you have, adaptabilities of cars. You can do so many other functions in terms of, you know um, uh, your device, your vehicles that you use, whether it's a two-wheeler or a three-wheeler or a four-wheeler, and these are already available in the market extensively. So environment control units, how do you help people with disabilities control the environment, like televisions, lights, switches, doors, windows, communication, typing, artwork, computers, sports, extreme sports. We're not talking about just, basketball on a wheelchair or something, but people, want to engage in extreme sports. Olympics, the Paralympics is a typical example for that. So voice recognition systems, which allow you to, work with interfaces, not only just for typing, but also will allow you to, use commands, and different adaptability switches of various forms that can be used based on the patient's function. Like a quadriplegic can use his head movements, voice, so air, wind, um, and retinal. Recently, I came across something which uses your retinal scanner. So there are so many things that can be used in terms of adaptability. So we are really going in an area of rehabilitation, which is going to reach very far. There's a lot of prediction saying that in the next decade or two, the biggest vertical that's going to grow in healthcare is rehabilitation. And those who are involved in rehabilitation, you definitely have a very good future in terms of job prospects, in terms of opportunities, in terms of growth. Now, I don't want to talk too much about surgical procedures which are available. I don't think there are too many surgeons in the group. But yes, there are so many advances in terms of what can be done. For example, you have a brachial plexus injury, you have arm weakness. There are so many procedures for tendon transfers and various things. Children with cerebral palsy, we have so many procedures. We have surgeries for pain. We have surgeries for spasticity, and so many other things which are all available, which I'm not going to spend too much time on. We can do so many of these. Nerves can be transferred to muscle in order to give functionality. So your team should also involve a surgeon who can give solutions to various problems. Phrenic nerve stimulation, your brachial plexus injury, we can have this accessory cranial nerve which can be used, facial nerve can be used. So many things can be there. So there is life after trauma. And as I said, people now come to extreme sports even after a spinal cord injury, and it is possible. And in the recent Olympics, there are so many people who had enjoyed and won medals just based on how much they could train and the level of disability. I want to conclude by talking a little bit about stem cells in spinal cord injury. This is a common question that many people ask me. Are stem cells for stroke, for spinal cord injury, brain injury, whether it is a hope or a hype? There's a lot of advertisement in the media. One of the first few articles that came about were from East Asia, China, Korea, and other countries, that there's a hope coming up that after so many years somebody is walking. So these are all very anecdotal cases of media observations, which are not randomized studies, which are not systematic studies. It is not very reliable. We don't know what it is. Even the Superman did not survive a spinal cord injury. So this is Christopher Reeves, that some of you may not know. He was the first Superman character, had an accident, and he was the longest surviving high cervical quadriplegic for many years. And then finally he died. So spinal cord injury is only a hope. It is not a hype. Um, you should not confuse yourself with whether it will give benefits. If they do not participate in rehabilitation, they're just looking for a cure, then yeah, stem cells is definitely not the treatment. The ICMR has strictly said that there is no evidence at the moment for stem cells. So if anybody is recommending or doing stem cells, it is against law that you're in for spinal cord injury in specific. I'm not aware of any precedents. So and do not encourage your patients as well, because it may not be harmful, but it is not going to have benefits, and it is expensive. It is not cheap. So I think that comes to pretty much the end of my discussion about various topics. And the future holds good for many things, including stem cells. Maybe, yes, we might have some groundbreaking research that comes, which could revolutionize the way we do rehab. If there is a stem cell treatment option that comes up for spine, brain, stroke problems, and combined with good rehabilitation and combined with advanced rehabilitation, yes, definitely benefits would be there for patients. But at the moment, we only have to rely on good rehabilitation techniques and good personnel who understand rehabilitation. So I would take questions. I would end my conclusion by summarizing that rehabilitation is the need of the hour in healthcare. Healthcare professionals must consider, advising their patients to take up, because it's really a doctor's responsibility not only to operate, but after surgery to recommend what is best for the patient. So definitely in that terms, rehabilitation helps. And we have a rehabilitation center in Chennai called Hamsa Spine and Brain Rehab. It has been there for 3 years, and now we have 4 centers. And we've treated more than 350 inpatients and almost 3,000 plus outpatients for rehabilitation. And we have learned a lot. We have not been very advanced, but we are going into opening a new center in Chennai, one more center, which is going to be a little bit more advanced. And we have to adapt to what new technology that comes up, which is going to add value, because anything that comes with cost is going to be transferred to the patient. And most of the people in our society, unfortunately, are in the middle and upper income groups, where they develop some of these problems. And just having a robotic may give you a better look that, we have a robotic center, but really, does it add value to the patient is something you need to do. So take a very conscious call about what advances are required and whether the advances do convert into good outcomes. But yes, the future is growing and we will have lots of opportunity. Thank you all so much for being patient.
Thank you, Doctor. We have a couple of questions. Maybe can I start reading out so that you can answer accordingly?
Sure.
Yeah. So the first question is post-surgery rehabilitation.
Yeah, definitely. So, before I talk about post-surgery, the rehabilitation now is actually being called as prehab. So, for example, if somebody is going in for a knee replacement or a back surgery, the future is going to be about how we are going to optimize them for surgery and how to give rehabilitation after surgery. So you need to have a month of prehab. So you're strengthening the knee muscles, strengthening the back muscles, then you do the surgery, and then you continue to strengthen those muscles. So definitely post-operatively rehabilitation is very essential, very important, has a lot of benefits, and it should be seriously considered in all musculoskeletal conditions, trauma, polytrauma, in spinal cord injury. So if you do not do rehabilitation and if you don't have a motivated patient, Then the patient is going to go sit at home and say that, oh, let my pain get better, let me not move, let me not do this, that, and then it delays their recovery. Whereas there's lots of studies which have showed people who have had post-op rehab and not had rehab, and the outcomes are far better in the group who have had rehab than in the group who does not have had rehab. And also the outcomes are much better in those who have had prehab, who have had rehabilitation before surgery. For this is for elective patients, not for emergent, and then continuing that future. So definitely post-op rehab is beneficial.
Thank you, doctor. The next question is advanced functional approaches in stroke rehabilitation.
Yeah. So I think stroke is one of those areas where, rehabilitation is very essential, and there is a lot of advances coming up. I think my entire talk was based on that. Was about all the various things that's available for stroke patients in terms of virtual reality, robotics, coordination, hand-eye function, speech and language, psychological training, cognitive training through virtual reality. So everything that I spoke about is all applied mostly to stroke brain injury patients. So all those things which I mentioned can be used for stroke patients.
Okay, doctor. Thank you. The next question is the role of psychiatrist in rehabilitation.
Yes. So I think every member of a team is a very, very important in rehabilitation. I don't think anybody can say that, oh, this patient has more physical disability, and so only a PT or a OT has importance. What's a nutritionist and a psychologist got to do with all this? But really, having seen hundreds and thousands of patients, I think a psychologist or a psychiatrist plays a major role in rehabilitation. Especially, first and foremost, acceptance for rehabilitation is still very low in our country, both among patients and among their patients' attenders. So the patients really need to be seen by a psychologist. They need to prepare them and update them and talk to them and make them feel that rehabilitation is going to make a difference. So that's the starting point. Second is they also need to speak to their caregivers, because caregivers sometimes are the ones who actually discourage rehab, because they don't see any significant improvement. Somebody who's got a stroke, they're just watching there for 1 month and saying, doctor, he's the same as he was 1 month ago. So it's not like some dramatic change is going to happen in a month's time. So the caregivers need to be counseled, the caregivers need to be assured, because once they get bored, then they want to take the patient and go home. So psychological counseling, psychological sessions, treatments are very important, and every patient should be seen and every patient should be assessed, and they should be given the appropriate. Sometimes after you see them a couple of times, there may be no role for a psychologist, because the patient may be highly motivated, the family may be motivated, so there you really don't have a role. But most of the times, I would say 70-80%, they don't talk about it. They don't talk about their depression. They don't talk about how they are anxious, because there's so much emotional, financial, relationship losses that the patient has gone through. And the other very delicate things are what psychologists need to talk about, like sexual counseling. I mean, in patients with spinal cord injury, we don't bring up the topic about sexuality. And I think this is very important, especially if they are young, in their 20s and 30s, that to start the discussion, because it's still a taboo in our country. So we need to start the discussion about, okay, have you thought about it? How can you do? What can you do? So I think a psychologist plays a very major part.
Thank you, doctor. I'll go to the next question. Doctor, how many questions we can take? I have about 10, 15 questions. Can we take
Yeah,
up to 10?
another 4 or 5 more.
4 or 5 more. Okay, yeah, thank you. So the next question is, how many days required to rejoin duties after spinal surgery when working should be restricted?
Yeah, normally I would say, I mean, I cannot very broadly say. It depends on your surgery, how major, complex, or what it is. But generally, if you're supposed, say, doing a simple disc operation, you can go to work in 2 weeks to 3 weeks. whether it is the neck or the back. If you're doing a major fusion surgery or on a surgery for any chronic problems, maybe up to 4 to 6 weeks. But generally, the myth is that, after a spine surgery, you cannot go back to normal life. That's a very wrong myth. If you all don't know, Sachin Tendulkar had a disc surgery. He played 10 years of international cricket. Shah Rukh Khan had, spine surgery. He's still dancing happily. So I think, spine surgery would not stop you from becoming highly functional.
Thank you, doctor. Next question is rehab for multiple sclerosis.
Yeah. So I think, see, it's again a form of, neuronal degeneration and neuronal demyelination disease. So, everything that I spoke about really is what applies to them as well. So, in terms of multiple sclerosis, is usually functional problems have with weakness, sensory problems, pain, spasticity. So, all of these things can happen. If the brain is involved, then it's a different type of cognitive memory training. So yes, MS patients, Parkinson's, Alzheimer's. So all of these patients would definitely benefit from rehabilitation.
Thank you, doctor. Next question is the scope of aquatherapy for spinal cord injury patients.
Yeah. So I think aquatherapy has shown very promising results. Hydrotherapy or aquatherapy in reducing various complications. It's enjoyable, it's fun. The resistance training is more, the strength training is more. So definitely aquatherapy and hydrotherapy has far more benefits than regular therapy.
Thank you, doctor. We'll take two more questions, right? So
Sure,
one is
sure.
management of Bell's palsy.
Mm-hmm. Yeah, so Bell's palsy is most likely a viral infection which causes paralysis, lower motor neuron type of paralysis of the face. Here, the commonest therapy that we do is we put them on steroids to reduce the inflammation. And along with that, we give facial muscle stimulation. We do taping of their face. We give strength training to the facial muscles. So I think that is what is normally done in terms of uh, therapies. And they normally require this for a period of 2 to 3 weeks. And they usually recover by about a month or 6 weeks. So for at least for 2 to 3 weeks, you need to give them. Sometimes you can ask the patient to buy TENS machines and other stimulators, which they can use it at home as well.
Thank you, doctor. Next question is someone wanted to start a rehab center. So they wanted to know to start a new rehabilitation setup, what suggestions you will like to give? It would be in rehab setup or outpatient rehab.
Okay. So I think it's a good question and the right person you asked to, because we've just opened up a franchise for Hamsa. So both inpatient and outpatient. So you can get my number and you can contact me and I will guide you how to open a rehab. We already have our first franchise that's going to open shortly in Chennai. So see, I think, the interesting thing is, I'm not sure how many therapists are here, but I interview therapists, almost every week I interview a few of them who apply for jobs. And when I ask most of the therapists, what is your long-term goal? 80% of them say, I want to start a rehab center. And I just think about it and say, do you know how difficult it is to run a rehab center? We have a center for, nearly 3 years now, and we've got, a few branches. But the complexity of running a rehab center is very, very difficult. It is as much as running a hospital, because the requirements of patients are not just, an outpatient prescription and then you walk away. The expectations of patients are high, expectation of caregivers. You have to work with teams. Team building and working with a team of therapists who have different mindsets, different ideologies is very difficult. The PT thinks he's the most important. The OT thinks he's the most important. The speech and language therapist, she's neglected. The psychologist thinks that, oh, nobody's listening to her or him. Getting the team to work together is not easy. And so many people say that I want to start rehab center. I would ask you all to rethink, work in a rehab center first, understand the complexities of rehab, and seek guidance of people who run rehab centers. And collaborate with them, partner with them, get franchise models with them. So rehab is not easy, whether it is outpatient based or inpatient based. We are having both models now. We have 2 franchise that we are opening. So we are helping people to open up rehab centers. And I think that's how it should work. You need to have a support system, because a stroke patient can have a rebleed. A spinal cord injury patient with a tracheostomy, the tracheostomy can get blocked. All these patients have comorbidities, so they can have a heart attack, cardiac arrest. Anything can go wrong during therapy. So if you don't have the proper setup, and if you just say that, oh, I'm starting a rehab and 2 physiotherapists join together and start a rehab, you can run into serious problems. So it's okay to do physical therapy for very paraplegic patient, chronic paraplegic, but when you're dealing with patients with much more higher problems, you need an entire team. It's not just a PT OT run setup that you should have. You need to have an entire team. So I'll be more than happy to whoever asks that question. You can share my number and I can talk to them.
Sure,
Can we
doctor.
take one last question?
Yes. There is one question. It is how to handle the concept of hope and not hype in patients, sir.
Yeah, so it's a very important question. The way I follow, and this has worked for me, is if somebody comes in with a paraplegia, spinal cord injury, and say that this patient is not going to walk, I would tell it straight on his face that I'm sorry, you will not walk. The chances of you walking are extremely low, because depending on the type of injury and the type of thing, that this person's outcome would be bad. But the way you tell it, the way you break that news is very important. If I just go abruptly and tell the patient, you're not going to walk, and I walk away, then obviously that's a very wrong way. You demotivated him, you made him feel very low, and that is not acceptable. You need to first tell him what he can do best, what he can do without having just legs. So life is not just all about having legs. Or is everybody who has 2 legs happy? Is everybody who has 2 legs successful? No. So legs is a way of communication. Mobilization from one place to another. So you need to give them the positive side of life, that despite you being in a wheelchair, you can still be successful in life. You can still have a good quality life. You can still have a sexual life. You can still have a work-life balance. You can still travel. You can do everything, and we will train you towards that. So, but if you ask me a specific question, will I walk and run like him? Maybe not. You will not. So I think if that message goes in at day 1, patients will hate you for it. He will not want to talk to you for some time, but then he will accept it. He will come to terms with it. But the minute you say that, oh, don't worry, in a month or 2, you will become fine, you will start walking, we'll do this, we'll do that. You give him that hype, and you give him that, that wrong hope, false sense of hope, that will linger with them for a very, very long time. They will hold on to that little bit of hope, and they will neglect many things. And I've seen this repeatedly happen in our Indian setup. The mom will say, oh, the doctor said he'll walk. So she will not even buy a wheelchair. They will refuse to buy a wheelchair because they feel that if they buy the wheelchair, that he will never walk. So then they go into religious things, faith, they go to temple, they spend their money on all kinds of voodoo treatments with that small hope that somebody give them that he will walk someday. So I think, if you're not good at telling that information, don't tell it. Let the doctors do, and even not all doctors are good at it. So we have to train people at how to break that news and not give them false hope. Yes, miracles do happen. I've also seen patients who I said will never walk, who have walked. But 90% times it doesn't happen. So you have to learn that. And, we train all our therapists on all these things. And it's very important not to give false hope. If you don't know, leave it to the experts. If you're meeting a patient for the first time as a therapist and you don't know what exactly is happening, just don't say anything. Yeah.
Okay, doctor. I think we have taken up almost all the questions for the session. On behalf of MedPiper Technologies and Jonamed, we would like to thank you for joining us for the session on rehabilitation. I understand there are a lot of psychiatry involvement and a lot of positivity involvement in setting up a rehabilitation center and also helping the patients to do the day-to-day activities accordingly. Thank you, doctor, for sharing all these details. And maybe we can come back with another session on the advancements in the later, maybe next stage for another session for our audience. Thank you, Ms. Geeta, for coordinating this event so wonderfully. Thank you so much. Thank you, doctor.